Hello and welcome to this webinar on anger in veteran and military populations. A very warm welcome to all of you who have joined us for the live activity tonight. I haven't seen the latest numbers, but the ones I looked at were extremely impressive, so I guess that's a testament to just how important this area is. Welcome also to those of you who are watching us later on a video cast or listening on a podcast, and a very warm welcome to our panelists, and I will introduce them in just a moment. Before I do, I'd like to acknowledge the traditional custodians of the lands on which our panel and our participants are located. I'd like to pay our respects to their elders, past, present, and future. And given the context of tonight's discussion, I'd like to particularly acknowledge the many Indigenous men and women who have served in the Australian Defence Force over many decades, including, of course, in 2 world wars. My name is Mark Creamer. I'm a clinical psychologist, and I have a very long interest in the mental health effects of trauma, and particularly in veteran and military populations. And as a clinician, I of course see anger a lot in my clients and my patients, and so it's a really great honor and a privilege to be able to facilitate the panel tonight and to draw on the expertise of our panelists. So without further ado, let me introduce our panel. And first of all, I'd like to introduce Dr. Monica Moore. Dr. Moore is a GP with over 20 years experience in family practice and currently specializes in psychological medicine. She's the coordinator of the Sutherland MHPN group, and she's also a clinical educator running mental health training for GPs. Welcome, Monica. Great to have you. Okay, great. We've got you. That's great. I'm just wondering, Monica, you were in general practice for many years. Do you think that anger is a problem that GPs sometimes confront in their routine clinical practice?
All the time, for lots of different reasons.
Is that right? Okay.
Yeah.
So they would be used to the kind of issues that we're talking about tonight, and hopefully gain from some of the suggestions that our panel might have.
Yeah, and it might be anger because the GP is running late, or it might be anger because they can't get what they want, like a script, or it might be anger because of something that's happening in their lives, or related to their personality or PTSD. So it could be anything really. GPs deal with everything.
Sure. Well, I'm glad you gave that little list there, Monica, because I'm going to put you on the spot. You are the first, but rest assured I'm going to ask the others as well. So given the topic of tonight's discussion, what kinds of things make you angry, Monica?
Oh, look, I was thinking about that. I have a whole collection of pet peeves. At the moment, the thing that's making me angry is when I catch crowded trains and people won't move out of the vestibule so the other people can get in, and that just makes me really annoyed. But look, I understand sometimes, it's interesting because I do get angry a lot, but I recognise that that's my internal reaction, and that life doesn't have to be easy or fair. But yeah, I get angry all the time. It's
an interesting point, isn't it? And as our population rises and our cities get busier and busier, I guess it's going to put more and more of those kinds of stresses on people. But anyway, thank you, Monica. Thank you again for joining us tonight. I'd like to introduce our next panelist, Dr. Tony McHugh. Tony is a clinical psychologist, and he has worked for many, many years in the treatment of veterans and serving personnel with PTSD and related conditions. He is an expert in the area of anger, and particularly in veteran populations, and several years ago completed his PhD on anger and PTSD. So he's the right man to have with us for the panel tonight. Welcome, Tony.
Thank you very much, Mark.
We mentioned PTSD there, and I'm sure that we will come back to the anger in PTSD, but presumably it would be true to say that it doesn't have to be PTSD. We see anger problems in veterans and military personnel outside the context of PTSD?
It's an excellent point, Mark, and I think even beyond the veteran community, which is our focus tonight, we see anger in lots of different segments of society, range of stresses, psychological phenomena that get people's anger going, but particularly in relation to other affects. Anxiety is a classic. Hard to know whether anxiety begins and ends and anger begins and ends, and that doesn't have to be in the presence of traumatization. And it's a rather stressful world. I think Monica's made that point already. Commonly anxiety, depression, emotions of responsibility are very associated with anger.
Okay, Good. And we will undoubtedly pick up on several of those points, I think, later, important points. But let me put the spotlight on you, as I did to Monica. Tony, what kind of things make you angry?
Well, I'm going to quote the great Averell, Mark, from 1983 in his seminal article. He says, most people experience an episode of significant anger at least monthly and most likely weekly. I don't know what my average is, but I'm an average Joe. People who experience anger are described in the literature as respected and nice people by Averell. But the things that get me going are inconsiderateness, contrariness, specialness, sense of entitlement, expectation, particularly when it's extreme.
Fine. Good list there. And again, I'm sure we'll come back to many of those, Tony. Thank you very much, and thanks for joining us tonight. Our final panel member tonight is coming to us from what I suspect is a very, very chilly Hobart. Dr. Jonathan Lane is a psychiatrist with a strong and long interest in veteran and military mental health. He's also served in the Australian Defence Force for 27 years, both full-time and as a reservist. So ideally placed to talk to us about anger as it relates to serving personnel as well. Welcome, John.
Thank you very much.
I don't want to cut across anything that you might want to say later, but I guess we hear a lot about anger in veteran populations. Is it a problem, do you think, also for currently serving personnel?
Oh, look, it has to be. I mean, anger is just basic to human nature, isn't it, really? So it's got to be the same thing with serving personnel, and as the other panelists have discussed, it's the same for everyone everywhere.
Yeah, absolutely. And I guess one of the things that we'll be trying to touch on later is, is where it crosses the line between being a problem and where it's kind of. Anyway, we'll come back to that. We'll come back to that. It's not preempted. Yes, put you on the spot as well, John. What kind of things make you angry?
Yeah, look, entitled people. Sorry, they just really piss me off. So basically people that are rude, arrogant and entitled and have this sense of justice, as in, and expect other people to provide it for them. That just sort of gets my goat, really. Yeah. Entirely too human, I think.
Yeah. And we see them in all walks of life, but we see them, I have to say, sometimes in the veteran community as well, I guess.
Yes.
Okay, so thank you very much to all our panelists. Let me just take a minute to tell people about the context for these webinars. This is the fifth in a series of 6 DVA commissioned webinars on veteran and military mental health. So we started off with one on veteran and military culture, one on PTSD, one on sleep, and one on substance abuse. And if you missed those, they are available from the DVA at Ease website, which I must say, just to put a plug in, is a great website. So they're available from there, and they're also available from the MHPN website. So if you missed them, do catch up on them there. Tonight we're talking about anger, and then the next one will be on the impact of mental health problems on veterans' families. Now, I'm a bit behind with my slides. I do apologize about that. There's our panel, and that's the webinar series. So let's go on and talk about the learning outcomes. You've all had a chance to read Darren's case, and we're going to be using Darren's case example, which is really, it's a very common kind of presentation. It's a kind of amalgam of cases that we've all seen over the years. And we'll be using that case as a kind of platform, a context, to drive our discussion about a whole range of issues in the area of anger in veteran and military populations. So although we're going to use his story, and Darren is a veteran, I would make the point very strongly that I think pretty well everything that we talk about tonight is equally applicable to other populations for whom anger is a problem. So many of the other people you see, and particularly I think emergency services workers and other similar kind of organizations, we're going to see similar kinds of issues. So the learning objectives are there on your screen and fairly straightforward, that we want to improve people's people's understanding of the epidemiology, as it were, the prevalence, the nature, the risks associated with anger in this population. We want to increase knowledge about evidence-based treatments and ways of managing anger in this population. And by doing those two, of course, we hope that we will increase people's confidence in supporting and managing veterans and indeed their families where anger is a key problem. In terms of the format tonight, I'm going to ask each of our panelists to give a 5-minute maximum presentation from their perspective about the issues raised by Darren's case. So we'll go through the 3 presentations, and then we'll open it up for a broad discussion, which will be driven by questions from you and questions from the panel. So without further ado, I'd like to hand over to our first panel member, Monica, and get Monica to talk about your perspectives, Monica, from a GP perspective. So over to you, Monica.
Okay, thanks. And so when I am going to talk about these slides about this case, just a little bit of an overview that I was responding to a previous version of the case. And so some of the things have been slightly changed, but the points that I'm going to make do apply, overall as a generality. So one of the things that we GPs do is we see the whole person, and so we often do an assessment based on their personality style about how we're going to have our relationship with them, because if we don't take that into account and treat everyone the same, then we're not doing the best for them and the best for us. Because their personality style influences how not only we're going to interact with them, but also their prognosis. And so one of the things I suppose I noticed from this case was how well he responded to structure, and that he just had a sort of a problem dealing with normal adversity like grief by only, spending time with his brother and drinking alcohol to excess. And that he had some difficulty seeing other people's perspectives and very high expectations of himself and others, even in areas where and situations where doing the right thing and having the right thing is impossible, such as the theatre of war. And so some degree of black and white thinking. And that is something that we GPs have to bear in mind when we're actually dealing with someone, because it actually influences how they're going to respond to us, as well as how they're going to see the problem either within themselves or within other people. And then when we're thinking about the things that are going to help us build that relationship, that trust relationship with him, so that he can then feel more comfortable, not just to talk about what's going on with himself, but accept treatment that we prescribe. I found that with these people that being punctual, so for example, in general practice, we're always running late. Well, I don't know about you. I mean, I was always running late for whatever reason. And so scheduling his appointments at the beginning of the day or after lunch, making sure that at the beginning at least he would have that regularity would be a good way of building up trust. And then also explaining the rationale for my questions. What am I doing in terms of why I'm examining him in this way, because he's presented with headache and pain, the investigations that I'm going to do and not going to do, the treatment options, and really explaining the boundaries early, that although anger is an internal process, and it's an emotion that we all feel when something isn't right, but it's the behaviours that are the problem. And so certain behaviours are not acceptable. And explaining that, I expect him to be courteous, not just in the room, but also to the reception staff. And that if he's got a problem, that I really want to hear about it and I want to solve the problem, but that it's important that he communicates with me in a way that is respectful. The first appointment, of course, is always when you're trying to find out about this person, and you wouldn't have got all of this history in the first appointment. You might just get that he's got a headache, that he's someone who, has seen military service, and about his concerns. And so the really important things are having a risk assessment in terms of suicide and self-harm, and also PTSD screening. Asking, because, anger in the context of PTSD is behaviour that does not change depending on what the environment is. So someone who has an explosive episode of rage in the context of PTSD does so whether there's a policeman next to them or whether it's, a small person in front of them. Whereas anger, which is more related to their personality style, if a policeman comes, they can immediately change that behaviour. And that's something that, we need to bear in mind, that there is mental illness, which really sort of hijacks your brain, and then there is other types of behaviours which arise and can be controlled by the patient. And that's important information that we need to ask him about. And of course, because we are GPs, we're going to be asking about his symptoms and a targeted physical examination, because he's coming with headache, some relevant investigations because of his alcohol, at least 4 blood counts and LFTs, and validation of his experience, that he's been through a lot, that it's really difficult, that we're there to help, and then suggest a prolonged second appointment so we can discuss things in more detail and review his results. And in terms of that second appointment when he returns, we do have the ability to spend more time with him and to be adequately remunerated by having the GP care plan. And so that's where we might find all this other history and to put together a biopsychosocial model to plan his care. And one of the things that I do with my patients is that I actually sort of fill in the boxes with their assistance, and then I negotiate with them where they'd like to start. Do they want to start in their social connections? Do they want to start by seeing a psychologist to deal with their mood? Do they want to talk about, their behaviour or even their activities? Do they want to join the gym again? And offer the services that the DVA has to offer, because there are anger management groups, individual therapy, and also support them with regular review. And Darren, comes with not much social support. He doesn't have a family. Tanya is no longer involved. But we often see these people in the context of their family. So they've got a partner, they've got children, and this behaviour, of course, is going to have an impact on them. And so involving the family early by getting permission from the patient to do so, and really highlighting how beneficial it is for this to happen, and negotiating with them, who do we get in touch with? Who do we contact when we're concerned about them and about their psychological well-being, so that they can feel supported, and the carers and those around them can feel supported, that they know what's going on and they know what to do in cases of crisis. And I think as GPs, we can really be supportive, and we can really give them a lot more than just treatment for their problems. Is that holistic care that we GPs can do. And then that regular review needs to come in the background of self-care for us, because people like this can trigger us. They can make us feel scared and insecure or angry at them, at their behaviour. And so I am a member of the Australian Society for Psychological Medicine, and one of the things that we do, we're a peer support group, we support each other, we offer regular training in psychological medicine, and these are the things, it doesn't have to be with that organisation. It can be with friends and colleagues, or having a regular supervisor that you discuss this and get support from. And I think that's really important for us. Yeah. So that's all I have to say.
Lovely. Thank you very much, Monica. There's loads of stuff there, and I really would like to pick up on that last point that you made a little bit later on about looking after ourselves, and how it, what effect it has on us. But can I just come back quickly and just a very brief answer? My guess is that, I know that a lot of these people are pretty ambivalent about seeking treatment. Have you got any thoughts about what it is that usually tips them to the point where they do actually turn up and they do ask for help? Is it a common theme?
No, because it depends on the motivation of the person. Every person is motivated by something different. And so, the thing that makes them come in is often, when you ask them, what was that thing, the straw that broke the camel's back? What made you decide to make the phone call and come for the visit? And each person will have a different answer to that. And that's actually really important information, because that's what motivates them. So, for example, with Darren, it might be that he's, saying that he might end up in jail. I mean, I don't know. I would have to ask him, because he's thinking that he might hit out at strangers in the street who annoy him. And if that's what he's interested in, then, if he's not quite sure whether he wants to engage in psychological treatment, I say, well, look, on the one hand, you're not wanting to engage in psychological treatment. I can certainly understand that it's difficult to go to a stranger and to tell these really personal things. But on the other hand, you don't want to go to jail. So what can we do? How can I help you? It's what motivates them.
I was just going to say, actually, sorry, I interrupted you there, because I was just going to say it's kind of a motivational interviewing in the early stages, isn't it, to build that, to build that motivation. Great. Thanks very much, Monica. We will certainly pick up on several of those points later. Let's move on now, though, if we could, and hear a clinical psychology perspective and perhaps a little bit about some of the latest research from Tony McHugh. Over to you, Tony.
Thanks, Mark. And I'm very pleased to be here talking about this very important topic. Good evening to everyone. My slides are very different. They're busy. I'm going to skate through them. They're there as a resource to you. I think we've already made the point that anger is a normal human emotion. We're talking about dysfunctional anger, what might be called dysfunctional anger. And sadly, there is no well-described set of phenomenology for dysfunctional anger. think really important thing is to talk with people about their anger and have them understand. If we think about Darren, the things that I picked up about him were he was questionable insight, and chaos was a feature of his life at various points. So I think to talk with people in an educative role around the negative impacts of dysfunctional anger, and you see them there: diminished intellectual performance, task completion, mistakes, accidents, mishaps, alienation of the self from others. What do I mean by the blue singlet brigade? I mean often the only people who can tolerate angry people are angry people. And humiliation, cynicism about other people. We civilians are often described as nobbers, for example. Not my term, their term. Frequency, intensity, duration, and absorption separate normal human emotion of anger from dysfunctional anger. Prevalence is unclear. Again, I'm going to talk a little bit about the literature base and how it lacks compared to other emotions and affects that we study and treat. So, intermittent explosive disorder in DSM-5, 4% of the population maybe. That's probably the best stat that we have available, but very, very under-researched. Elbridgen makes the comment, interestingly, because we're talking about a military population, that the current veterans that have come back from conflicts over the last 20 years are noted to be the angriest veterans in the history of the Western world. So when it's present in an ongoing, smouldering form, anger is associated with lots of things, but these are all key motivational points that I've mentioned, but particularly this one, morbidity and mortality. And you only have to look at the literature around cardiac disease to know that smouldering anger is actually a killer. Here's some of the evidence base. There's been about 12 meta-analyses done over the last probably 20 years. They basically say the same thing. We don't fully understand the mechanisms that sit behind anger and make it such a problem. They talk to cognitive therapy in that top right-hand cell, CT, as being very effective, nearly as effective as relaxation, which, surprise, surprise, is the most singly effective component, and multi-component treatments as being very important too. So if you keep in mind cognitive therapy, disputation, and all the other tools we can use, relaxation, there's an article called Looking Inside the Black Box by McIntosh, which I'll refer to, and it basically says we need to get people to calm down. So very important evidence base. Basically, we're moderately good at treating anger, not as good as we are in relation to other affects that are negative in nature. The art of treatment, get away from the science for a minute. Important that we're all knowledgeable. I'm going to talk about this in a moment. Be methodical and structured, and Monica's referred to this already, and the literature says repeatedly. There's a 2009 meta-analysis by Saney that talks about manualised interventions maximising outcomes. We've known that for a long time. It comes up in the literature time and time again. Be structured, try to be manualised in approach if you can. And adopt a model of anger that's personalised. Different models will suit different people, and there's some really good ones around. Many people may know about the ChemTOB dysregulation model. It follows the work of Selye from a long time ago. I also like Bandura's learning model, which Terry Keane picked up in relation to military training some time ago. So adopt a model for a particular individual, and you're allowed to have different models, but don't confuse people by throwing more than one model at them. Art of treatment, persist in it. There are rarely quick fixes. Anyone who's had anything to do with the military and veteran population will know about the 7 Ps, that is prior preparation and planning, prevent piss poor performance. There are no quick fixes. If we want to assist people to be better at managing anger, we need to be structured and persistent. And it's the eyes on the prize, because once people understand that they're actually losing by being angry, when do they want to change it? Now, and they can't have it. That's the reality. There's that McIntosh article again, peeking into the black box. In 2014, it talks about the need to be very serious around calming people by evidence-based relaxation methods, combination approaches, and above all, experiential interventions, and beware of the nature of in vivos, and do not mythologize the light bulb. It simply doesn't work. A word on self-instruction training. The great Donald Meichenbaum talked about this in the 70s and 80s, and Ray Navarco picked it up in the 90s. It is literally instructing people in how to not get angry in predictable situations. And Phoenix has done a study on this that's yet to be published, that looks at an effect size of 1.6. If anyone knows anything about effect sizes, that's off the scale. That's a treatment effect that is pretty amazing. And the literature has pointed to self-instruction training getting these kinds of results before. So it's a bit overlooked, but I actually recommend it highly to people. Much is known about the nature of anger. As I said, I would get to this slide. It's often an avoidance emotion, strongly related to other negative emotions. I made that point earlier. It is an externalizing emotion and not about the present. It's often about the past. It's about a whole range of things, childhood, adolescence. It's about pre-trauma impacts or factors. It's about what happened at the time. And it's often about, as we see in Darren's case, what happens to him after he's traumatized and returns. And often we refer here to the iceberg of emotion. You see 1/9 of it, there's 8/9 of it going on below the surface. There is a neurobiology of anger that interacts with the mind. Everyone knows about the limbic system and the shrunken hypothalamus, but how much do we know about the left prefrontal cortex? And it actually causes people to go towards the problem, thinking they're going to do positive things, and afterwards they count the cost. Anger can also be volitional and involuntary, and Monica's made that point in relation to personality disorder. It's really important to understand sometimes people bring anger on because they want to solve the problem. The problem is it becomes less and less effective with multiple use. That's the law of diminishing marginal returns. And both types are involved in rumination, which doesn't help anyone at all.
I'm sorry, Tony. I'm going to have to move you along a little bit. We're very short of time tonight.
I understand that, Mark.
So if I could just give you one more minute, maybe.
Yeah, will do. So anger and trauma and PTSD go together. Anger prolongs PTSD. It's a chronicity agent, if you like, and it mediates treatment efficacy. Anger intrusions are associated, and there's even a lone study in the US that says people don't have to have a full set of symptoms. Just the intrusions will actually cause anger-related PTSD. None of this is understood by our clients. It's our job to facilitate that with them. There's some tips for you to think about. The biggest tip I think I can say is there's a clear literature around venting, and people need to understand that the worst thing we can get our clients to do is to actually vent. It harms relationships, it turns people into enemies, and it's really not evidence supported at all. Mark, I might leave it there with that last slide of tips, and we can come back to them as required.
Wonderful. All right, thank you very much indeed, Tony, and I apologise again for having to move things along. Okay. But as you say, as we go into the general discussion, I'm sure you'll have lots of opportunity to pull up some of those points. But time's going on, so let's move on to our final panel member and get a psychiatry and also a serving member perspective. Over to you, John.
Thanks, Mark, and thanks to Monica and Tony as well. They were both really relevant and really pertinent to the discussions. I suppose I'm coming at it from a slightly different perspective in the two slides I've got up here. And the first one is that from the military context, anger is a trained response. And so it's a safe response for people to actually engage in. And so, you know, in terms of basic training, people are encouraged to get anger and to use that emotional power, I suppose, for lack of a better word, to overcome adversities and overcome challenges. You know, aggression is trained in people because what you're trying to do is get them to fight in many ways and shapes and forms and things like that. You know, if you think about anger being a safe emotion and as that construct, the opposite of anger might be perceived to be calmness or whatever else. But it's not like people can sit down and go, oh, I'm feeling really sad, or I'm feeling really distressed, or I'm feeling whatever else. You know, what they can do though is they can get angry about things. And so the anger can serve the purpose of, you know, defensive protection from themselves and what they're going through in those sorts of situations. It can provide anger and give them the strength and the power to get through. It helps externalize things, it helps blame, and it helps protect our own self-identity as well too. The other sorts of things as well is that anger is realistically, in the veteran population particularly, as well as in a bunch of other people, it's often about emotional dysregulation. So if I'm sad, if I'm angry, if I'm upset, anything like that, the way that's going to be expressed is through means of anger towards other people. So the more we can sort of focus on, regulating our own emotions, then the better off we're going to be. And the self-instruction training that Tony talked about is a great example of this. I haven't included it in my resources, but what I often refer people to, is the DVA high res, so the high resilience application, which is phone-based for iPhone or for Android or anything like that, which has a lot of different techniques for people to actually de-escalate and decrease their emotional arousal. I talked before about the emotional response type stuff. And this is where it really gets hard, because people get stuck into this loop of, if there's a problem, then I have to attack it. Now, and whether that's, defensive self-fulfillment of things, whether that's a trained response or whatever else, as the other presenters have also talked about, it becomes a negative self-reinforcing feedback loop, and it just causes more and more problems because, again, people use anger and therefore aggression to try and solve problems which are externalized. It might work for a short period of time, but it doesn't work for very long. And so what happens is that sets up the justification loop for blaming other people, so externalizing responsibility for issues and problems, and basically decreasing one's own, inherent capacity for efficacy and to change the circumstances and situations that people are in. So what I often find with people, when I'm dealing with them, is not just sort of focusing on the symptoms of anger, but going, why are you actually angry? Second thing is problem-solving approaches in terms of dealing with those sort of circumstances and situations that trigger us. But the other thing is, why do we need to externalize? Why do we need to blame? Why do we need to be right about things the whole time? Why do we need to justify why we've been treated poorly? So, whether we talk about acceptance and commitment type models, or we talk about just straight out emotional regulation type issues, being able to actually increase our own self-efficacy, take responsibility for our situation, take responsibility for our behaviour, and engage in adaptive coping mechanisms instead of, the effective, immature juvenile temper tantrum rant, that is going to certainly make life a lot different for a lot of people as they're going along. This is obviously practice, and this is obviously difficult because we are getting people to do things that, might actually be quite foreign to them. And, these are the main set of challenges that we face. And again, as was mentioned, it can be a slow process. I suppose the other reason behind the slow process thing is in some ways going back to the emotional regulation model. As clinicians, we are actually serving a reparenting role in terms of boundaries and, increasing internal efficacy and internal responsibility. And so as Monica talked about, having that regular framework where you're not going to be running late, as Tony talked about, not being opaque, being quite clear and those sorts of things. These are really fundamental because, there are a lot of personality type elements that come out here, and narcissism is certainly a big part of that as well too. And so the more we can operate, quite clearly, quite above board and making it really quite obvious about what we're doing, and that our job is to help people help themselves, I think the better off we're going to be. So basically that's my slides.
Great. Thank you very much, John. Lots of really good stuff there I want to come back to. Certainly the point you make about essentially this being an adaptive behaviour during their military career and being able to make that transition to civilian life. I'll just leave it there because I really want to come back to that. But can I just pick up on one thing? I entirely agree with that last point in your slide that we need to look at the underlying problems that are precipitating the anger. But can I just digress and just ask, is there any place at all, do you think, for medication in managing anger?
Look, there certainly is because, again, as I discussed in terms of underlying things, and as the other panelists have described, anger is always going to be associated with something like PTSD, but, anger is also very much a strong part of the diagnostic criteria for major depressive disorders. And anger and therefore irritability are always going to be, coping mechanisms for people who are anxious, or got social anxiety and those sorts of things. Because again, anger in that sense of a defensive reaction in order to protect yourself is a great way of overcoming your own personal deficits and insecurities. So, again, coming back to that whole concept of emotional regulation and being able to deal with changing emotions and being able to have a sense of self-efficacy and having control over your environment so that you can actually let things go and not need to react to things. You can actually choose to respond. And the difference between reacting to things and responding to things is one of the key points that I really like to try and get across to people, because a reaction is always going to be emotionally based. And it's, as was mentioned again before too, it's going to be highly influenced by whatever emotions are going on. And the logical, rational parts of our brain are not generally going to be involved. And afterwards, then we've got to deal with the shame, the guilt, all the other sorts of things and the consequences of what our reactions actually led us into. So, yeah, very much so.
All right, good. Thank you very much, John. So thank you very much to all our panel members. We're going to move now into the broader discussion, and I'm going to invite the panel to just jump in whenever they want to, and I'd like them to, if not disagree with each other, then at least present alternative perspectives where it seems necessary. But most of the discussion is going to be driven by questions that we've had from you. I must say that I've been extremely impressed with the number and the quality of the questions that we've had from the participants tonight. And I would love to work through them all and answer everyone in turn, but unfortunately there were literally hundreds that have come in over the last couple of weeks. And so we can't do that. But I hope we'll get through most of the major themes. And please bear with us if we don't get to your particular question. To help us work out what you think is important, though, we're going to actually have a bit of a poll. And so we've grouped the questions that came in before tonight into 5 major categories, which you can see on your screen at the moment. And we're going to give you 30 seconds to vote for which of those you think is most important. So when you're ready, Gianna, if you can start the poll. And I'd like everybody to just put let us know which you think is the most important. As I say, we've got 30 seconds to do it. We'll try and get through all of those areas when we can, which I think we probably will do. But it's always interesting to see what's important. And I can see the numbers as they're coming in, and there's very, very clear. Yeah, anyway, your last chance. Anybody else want to add any votes? Okay. So, Gianna, if I can ask you to close the poll and then bring up the results for people to see. And the one that has come out way above everything else, I don't know if you can see it, if our participants can see it, but I certainly can, is the area of managing the risks and de-escalating anger, which I guess is something that really speaks to us as clinicians when we have people who are angry in front of us. So great topic, and we will certainly get onto that. I'm going to ask you to bear with me because that's kind of taking us into managing symptoms and treating and so on. So I'd like to just go back a little bit, even though it's not your preferred one. Don't worry, I'll make sure that we get to them. And just go back and talk a little bit about the nature of anger. And I guess, several of our panelists have alluded to this, but the idea about whether or not anger is problematic or not is usually considered to be a negative emotion. And I guess if I could ask our panelists whether they think that's legitimate and when perhaps it becomes a problem. Tony, do you want to kick us off on that one?
Happy to, Mark. It is classically called a negative emotion, and along with anxiety and depression is considered the big 3 negative emotions. It's what humans experience most commonly. It's what people present in treatment for. But I guess I've got to say this about anger. It's got more positive functions than anxiety or depression from my reading of the literature. It's about correcting wrongs. Monica's made the point about justice already. It's about communicating sometimes difficult matters. It's about dealing with difficult stuff, sometimes including bereavement. There's a natural irritability that occurs after bereavement. It's about protecting people who depend on us. So we really need to have a balance around how we view anger. It is a negative emotion. It has very serious consequences. I go back to my earlier comments on one of the slides that we really don't have, and I'm not just making this point, the literature makes this point. We really do not have a concise understanding of when anger becomes dysfunctional. The point is made in the literature that we're often studying people with anger problems or giving them measures that measure problematic anger, but we haven't described the phenomenology very well. So I think there's more positivity about anger, but its negativity is surely very, very impactful on individuals.
And I suppose we would argue, wouldn't we, that along with most clinical things, once it starts to interfere with social and occupational functioning, particularly social relationships and so on, it's going to be a problem. I wonder if I could ask people, I might bring you in here, John, about, and again, a number of people have alluded to this. Do you think that there's maybe a difference between what we might loosely call reactive anger and what might be instrumental anger? You know, one a reaction to a perceived injustice and the other maybe a way of getting things done. Is there a difference between the two?
Oh, look, there most certainly is, because, you know, there is a certain form of pathology where people learn quite quickly that when they engage in shows of anger, so perceived anger, you know, directed towards someone else, which is actually aggression, not necessarily anger, actually gets some results. And so particularly towards healthcare staff, towards other people, this is the basis of, you know, domestic violence, interpersonal violence. And it's also a way of, you know, asserting dominance, again, protecting yourself and then achieving things. However, you know, it's a very immature type response to things, isn't it? Because it doesn't engage people socially, and it doesn't help form intimate personal relationships with people that are supportive, nurturing and protective. So, you know, it really behoves people, I suppose, to have a look at what forms of anger, you know, the patients or the people that they're dealing with are presenting with. Is it, you know, reactive or responsive, or is it instrumental? You know, I like the fact that I can get away with these sorts of things when I'm intimidating and threatening by showing anger or whatever else. And, you know, again, as Tony was sort of talking about as well too, anger can have a lot of positive things. And as I briefly mentioned, from a military perspective, anger lets you overcome fear, lets you overcome anxiety, lets you achieve boundaries, lets you protect yourself, and lets you get away with things in some circumstances that you might not otherwise get away with. So it can be a very positive emotion for a lot of people. So yeah, very much.
And yeah, powerfully reinforced for them sometimes, I guess.
Very much, yeah.
I want to kind of gently move the discussion on to the relationship between anger and other conditions, but you know, to what extent do you think, I'll start with you, Monica, because this was your first slide, but to what extent do you think anger is often or usually a reflection of a particular personality kind of style, sort of underlying issues beyond the more recent training or stressors? Is that a personality thing?
Yeah, I suppose it's just my impression that certain personality traits like perfectionism tend to be more prone to feeling slighted, to taking offence, I suppose is what I mean. So, for example, if I'm running late, the person who doesn't have perfectionistic traits will just say, oh yeah, GPs run late, that's okay, that's the way life is. And someone who never runs late themselves then, you know, gets very angry and has to have that validated. Yes, you know, for you it's really difficult. So, yes, personality style has something to do with it. But two things arose, you know, I was thinking, this is my first webinar and I forgot to say thank you for inviting me at the beginning of my session. And so I feel a bit ashamed. And so I actually think sometimes shame is what's underneath a display of anger, you know, that we've been caught out or that we feel blamed in some way. And so we'll react in an angry sort of way.
I think that's a great point, Monica. But I would, sorry to interrupt, but I'd really love to come back to shame and guilt, because I think that's, you're touching on something really important there. And I just don't want to leave the personality one just yet. I just wonder whether John or Tony have got any comments about that. And I'm going to be provocative and say, you know, is the only reason that we're getting these high rates of anger in our veterans, is the only reason because they were angry people before they went in? Was this a personality style before they got there?
Look, I think, again, the training has to encourage those sorts of things. But I think that sense of emotional regulation is probably more important in terms of what happens to people. So, you know, people with combat PTSD, again, present quite differently to people with other forms of PTSD or other forms of whatever else. And, you know, again, thinking about that veterans culture, we have a strong sense of entitlement towards things in general, I suppose, in terms of veterans seeking things from DVA. And so going back to Monica's point about justice and the personality issues and whatever else, that sense of entitlement reinforces that sense of, perceived unfairness. I haven't got what I want, and therefore I'm right to be angry. And so I think that drives a lot of things as well too, and certainly causes a significant amount of distress because, again, looking at the people that present, are they angry because they're not getting compensation or whatever else, or are they angry because they're actually unwell? Giving people access to treatment under, the DVA non-liability healthcare stuff is an awesome thing. But a lot of people might not necessarily want to access that or engage in it properly because they're actually more interested in getting compensation or liability claims. So, yeah.
And let's take the discussion on then, because that question that Monica just touched on, I'll come back to you now, Monica, but I suppose the broad question that I'd like to kick around a bit is the extent to which anger is a problem in its own right versus being a reflection of something else going on and perhaps another disorder, perhaps another diagnosable condition. But let's come back to you, Monica, because I think this point you started to raise, and I rudely interrupted you, is a really important one. And I'll ask the others as well to come in, but in terms of shame and guilt, do you think that might be a key driver of anger sometimes?
Yeah, I think it often is, because, people certainly, someone who can have outbursts of aggression and violence, and they know that it's not acceptable. They know that it's not okay and that it has all these negative impacts. And I think it's important to make that claim that anger is an internal sensation. So it's something I know about myself that I'm angry. But my behavior externally is something that is related to what I'm trying to achieve. So I find it difficult sometimes when we talk about anger, because anger is my internal feeling, and no one will know that I'm angry unless I do a certain behavior that people can read. But the shame part of it is that if we normalize people's behavior, if we say, "Look, we're all human, we all do things like this." If we use Kristen Neff's self-compassion guidelines of, we're all human, practice a bit of self-kindness, and teach them mindfulness. I was thinking about, John and Tony made such good points about relaxation, and I use mindfulness techniques to teach people just to observe their emotions, to observe their internal world so they can choose better behaviors. And so in some degrees, normalizing it, saying we're all human, we all make mistakes, but, we can do it better. So let's learn to do it better, and just accepting that it's, shame can sometimes block their access to treatment as well.
I agree. I think that's very important. Very important. I guess sometimes with our veteran military populations, that becomes a little bit more difficult in terms of what we've asked them to do, and the whole area of moral injury and so on. I agree absolutely in principle. Tony or John, would you like to come in at all there about the role of shame or guilt? And I don't know if you've seen the papers this morning, but and probably over the last few days, there's been a fair bit of discussion about an inquiry into the SAS and their behaviours on deployment and so on. And a lot of these often, I think, lead to guilt and shame, and whether that comes out in anger. Is that something you'd like to comment on, either of you?
If I may go first, Mark, they're inextricably linked, and the literature points to this. And there's a guy by the name of Ed Kubani who's written extensively on guilt in PTSD, and he makes the linkages really quite clear. Inextricably linked. Anger is a response often to a sense of responsibility. I should have stopped something. I should have done better. Someone should have stopped something happening. And responsibility looms large often in people's minds, and it's very difficult to talk to. So it needs to be unpacked, and I think anger is often sitting alongside, inextricably linked with both of those emotions.
Can I just add to that as well too? When you think about the shame and the guilt sort of stuff, this is the internal dialogue of someone going, I'm a screw up, I'm useless, I'm hopeless, no one's ever going to like me, I'm just whatever. And then they come into contact with someone who potentially criticizes them, or the person perceived that they're being criticized, and therefore they're tapping directly into that internal dialogue which says that they are useless and they are whatever else. Is it really a surprise when people just explode? Because someone else is reinforcing and reflecting that internal dialogue going on to them. And then it's like, how dare you say that about me? How dare you act like that towards me? Boom, off it goes. Perfect excuse.
Yeah, absolutely. And when you talk about the internal dialogue, it's then perhaps not surprising what we saw on Tony's slide about cognitive therapy, cognitive restructuring being a valuable intervention tool. Just before we move on to, while we're talking about the relationship between PTSD and other conditions, I'm interested in the relationship with anger and other conditions. I'm interested in the relationship between anger and depression. And I seem to remember that there was sort of psychodynamic formulations that talked about depression being anger that's sort of pointed inwards, as it were. Is that something that you think has any credibility, Tony, or others?
If I may go again first, Mark, for those people who are tuning in and are members of the APS, this has been repeated again in the latest InPsych edition. It is a long-held view that you've described. Sadly, there's no evidence for it. Studies have repeatedly shown this. And if we cast our mind back to the 50s when Alice and then Beck, independently of each other, were looking at patients with depression in inpatient psychiatric settings, they actually came to understand that the then treatment of getting people to articulate their anger about themselves didn't make them less depressed. It made them more depressed. So no evidence that depression is anger turned inwards. It continues to be described, but it's not literature supported and evidence based. And it leads me to just say one other thing. I've commented on already. The logical consequence of believing that is to get people to vent their anger and their depression will lift. It just doesn't work, and it harms relationships. It actually is counterproductive. And the worst thing, there's an article by Brad Bushman in 2002, he said the worst thing you can do is exercise aggressively before or after an event where you know there's going to be an issue comes up. It actually makes people's responses even before the event if they exercise strenuously.
Interesting research. Okay. And perhaps a bit
counterintuitive. Mark,
John.
Can I quickly just tap into that and agree with it as well too? So that point of venting and things, you know, going back to my original comment about emotional escalation and the importance of decreasing those sorts of things, venting basically just engages in those same dialogues and perpetuates the emotions and basically perpetuates that need to let other people know how angry and how upset I am, and therefore actually, you know, poisons interpersonal, intimate relationships. And so people become more distressed, they become more socially isolated because people leave, and again it reinforces their need to be angry and to do whatever else. And so that pattern of destructive behaviour just continues, and so just makes everything worse, whether it's PTSD, you know, substance abuse, drinking problems, etc., etc. So yeah.
It's a very important point, isn't it? Given, as Tony said, that there's still a very widespread belief that this is a healthy kind of thing. I think it's a great point that you both made there. The other condition that we might consider with anger, of course, is PTSD, and several of you have referred to that already. So I won't go into that now, but we will come back to it when we talk about treatment and managing escalating anger, which, rest assured, I'm just about to do. Quickly, before I do that, I'd just like to come back to you, John, quickly. You talked about the way in which military training, may perpetuate anger, or may actually precipitate anger, as it were, train people to be angry. So can I get you to speculate, should we be doing more in terms of training to be a civilian at the point of transition out? Can we retrain people not to respond aggressively in civilian kind of situations?
Look, that's a really important point, and actually really topical as well too, because, you know, the Centre for Traumatic Stress Studies in Adelaide, the University of Adelaide, has been doing a bunch of research on, you know, the problems during transitioning, and, you know, you can see for the suicide rates of veterans who are transitioning from defence, especially if it's an involuntary, you know, medical discharge type thing, the suicide rates are 3+ times higher than the civilian population. And so again, what is an adaptive, you know, emotional coping mechanism during military service is not necessarily going to be, you know, adaptive and productive in a civilian environment. And so how do we teach people or help people to manage these sorts of things, not just in their daily lives when they're wearing a uniform, but in their interpersonal lives at home? Because, again, the common complaints from families, and I'm sure, pretty much every single clinician sitting out there listening to this will say, what about the effect on the families? How do we then deal with the kids who've been exposed to this sort of thing and then have their own issues when they're growing up as well too? And so, you have VVCS clinicians who are seeing generations of family members because of emotional arousal and basically emotional regulation problems that are expressed as anger, in amongst between people. So yeah, look, it's how are we going to do that though? How are we actually going to get that sort of training and skills and education stuff? Look, I mean, it's really difficult. I've been running some programs with mates on emotional regulation, and that to me is one of the key sort of factors, because it's a skills-based thing. And, the International Society for Trauma and Stress Studies basically says that the phase 1 generalised skills-based interventions are very highly applicable and appropriate for these sorts of things, because you give people a functional capacity to actually manage themselves, regulate their emotions, and then they can actually engage in treatment services effectively from then. But until they can actually do that, it's really hard for us as clinicians to manage them, because we're waiting for them to bring those skills to the table first so we can actually help them get better.
Yeah, absolutely. And we should go on and talk about that now. I just wanted to quickly make the point that, as you say, it's a very difficult thing to do to help people make that transition between what's appropriate within the military context and the civilian context. But I was very impressed decades ago now with a video that was produced by VVCS. I don't know if it's still doing the rounds, but it was called "You're Not in the Forces Now," and just actually doing some psycho-ed about the fact that this was useful then and it's not useful now. This kind of aggression was helpful on the battlefield, but what is not helpful now. Just that psychoeducation, I think, can be often very, very helpful for people. So at least as a starting point. But let's go on, because it was a topic that most people wanted to talk about, and it's clearly the most important thing that we can do. Well, one of the most important things we can do tonight is to talk about how we manage anger in our clients, how we help them to manage it really, how we de-escalate situations. And I'd like to kind of talk initially about acute escalations of anger, and particularly how we might manage it in our consulting rooms when someone's beginning to lose it, what we might do there. And then I'd like to go on and talk a bit more about treatment. But let's start with the former. And I know you have just been talking, John, but I know that you've got some ideas about this. So if the others will forgive me, I'll come back to John first, and then we'll go to the others. Ideas about how you might de-escalate anger in the consulting room.
Yeah, look, first of all, depersonalise it. So it's not necessarily about you. You just happen to be the target of the person who's venting at you or doing whatever else. And again, what we need to sort of start reinforcing and modelling in our own interactions with people is that the behaviour is not acceptable. So aggression and anger is not acceptable, because it's toxic. And as clinicians, being exposed to that is incredibly stressful for us. And we aren't going to last long in our jobs if we have to deal with those sorts of things. So full stop, end of story, not appropriate. And so when someone is venting like that, the first thing is literally, time out, stop, de-escalate. So go through your breathing techniques, go through your grounding techniques, those sorts of things. Give it 30 seconds, give it a minute, and go, right, we're talking about the facts here. We're not talking about perceived injustices. We're not talking about blaming. We're just talking about the facts of a situation so that we can depersonalize it, but literally take the emotion out of it, because it's the emotion that causes the escalation of the anger and therefore the distress and so on and so on. And so that's the first step. I'll throw it across to the other guys to sort of take over from there, but just, depersonalize it and don't put up with it.
Would you go along with that, Monica? Or, what are your thoughts on this?
Yeah, I must admit, because I'm thinking as a GP, the sorts of practical things that I do. And so when someone is clearly angry, and I'm thinking about, John, what you said, and yes, a lot of it is not to do with me, but sometimes it is something to do with me. Sometimes I am running late. Sometimes I did make a mistake with the script. Sometimes, the appointment that I thought that they had with the specialist was the wrong date. So I need to apologise. So sometimes we do need to apologise for our part in a misunderstanding, and say that, and validate that for the patient, that it wasn't intentional. I think sort of saying, whoa, that's a lot of anger there. Wow, I can hear you're really angry. I really want to hear what you have to say, but at the moment I'm feeling, like it's making me not want to listen because it's just kind of, a bit too strong. Can we just slow it down? So just slow it down and just tell me, what's the problem? I want to help you. And that can often be something where, I'm on your side. No shouting. I'm on your side. Now, what do you have to say? So those are the techniques. I mean, if I'm working with someone, more clinically, there will be grounding techniques and breathing that I will have been doing with them. But as a GP, often it's the first time or second time you see them. And, you really have to sort of say, if you keep on shouting, I'm going to have to, call the security person, I'm going to have to call the police, or, you know what I mean? Like, they have to know that behaviour is not okay. So those are the things I think as GPs we need to know. It's okay to say it's not all right, and I really want to know what's going on for you.
Yeah, setting those very clear limits is, I agree. You're both making that point very clearly, and I go along with it. I want to come back to you in just a minute, Monica, to talk about what you alluded to earlier, which is how does it impact on us. But can I just come to you, Tony? Would you like to add anything there? You would have seen plenty of angry veterans over the years in your treatment settings. Any thoughts about how to de-escalate?
Yeah, absolutely. Monica and John have made excellent points. I think slowness and measured speech is really important, and I made that point in one of my slides about not being opaque. Simple language that if we can validate people's concerns there and then, do it. If we can't because there's entitlement that's not reasonable and it's not the facts, as John has said, then we don't want to be colluding with people. So one of my tips was being really clear with people from the start about what's okay, what's not okay, and keeping it just slow and simple. And in one of my slides, there is something opaque from me. I talked about the elevator of affect. What do I mean? I mean that often anger is a secondary emotion. It's a response to something else. We've all made that point. The problem is getting angry doesn't allow the individual to address the underlying emotion. To deal with shame, you have to deal with shame, etc. So I think keeping it a really basic understanding that people are probably worried or scared or frightened or feel disrespected is really important. It helps you understand them a bit more and be measured, paced, simple in your language.
Yeah, good. All right, thanks.
Can I just
go on, John? Yeah.
Sorry, can I just say one more thing? Look, another really useful strategy for people, and I'm particularly sort of thinking about the female clinicians there as well. It doesn't work so well for me because I'm big and ugly, but if you make a deliberate point of going, wow, hold on, you're actually making me really scared with all this yelling and that sort of stuff, and actually using that as a technique to help the person mentalize and have the effects of their behavior reflected back to them. Specifically in, you're making me really scared. I'm feeling really nervous here because you're yelling and you're ranting and you're raving at me, and it makes me scared. And I don't think I can be with you when you're like this. That can actually be a really useful technique to help people see the effects of their behavior. And so again, actually helps them mentalize and helps them get some rational control over what's going on. If they don't do that, then you would have to start suspecting that instrumental aggression going on. So it's a good sort of therapeutic, trick as well too.
Yeah, absolutely. I go along with that entirely. Can I just come back to you though, sort of leading on from that, really, John, to your point, Monica, that this is not very pleasant for clinicians. It's not very pleasant for us when we're in these situations. We have very angry patients. And you did talk about this briefly earlier, but can you just, have you got anything else that you'd like to add about how we manage the effects on us and how we look after ourselves when we're working with angry people?
Well, look, prevention is always going to be better than the cure. Full stop, end of story. I spent a lot of my training time working in a prison environment, and you have lots of people who are really angry at you, and again, they might have reasons to be angry at you as well too. But again, what it comes down to is prevention is far, far, far better than trying to cope with it after it's happened. Because again, as anyone who's had the experience of a full-on tirade, you're really quite aroused yourself. And when you're aroused, you're not going to be able to deal with an angry person properly because you're going to be reacting and not responding. So Monica alluded before to having effective supervision, having effective safety mechanisms, having, appropriate security call buttons so that, you can actually do those sorts of things. If you have an angry patient or someone you think might be threatening, please make sure you between the patient and the door, so that you have an easy egress or, you know, escape route type thing. Have someone else come and sit in the room with you, those sorts of things as well. Because again, it's the same with interpersonal violence. When you have an audience member, people will often be more inhibited. And so by that I mean that they'll be less likely to escalate and less likely to respond angrily and those sorts of things. And again, going back to what I talked about, just saying, wow, you know, you're really scaring me. Yeah.
Can I just throw to you, Monica? I'm sorry, I meant that question to go to you anyway. So have you got anything that you'd like to add, Monica?
Yeah, I'm thinking, I mean, John and Tony are saying, you know, basically what I would say. I mean, the only other thing that I would say is that afterwards we do need to debrief and we do need to have some sort of sense of how it was for us. And so sometimes we can't do it immediately. And sometimes we're busy, we've got to see the next person. And I do know that for me, sometimes I could just use a mentalizing exercise where I could imagine this very strong container in my room where I was going to put the stuff that was distressing me and I was going to lock it up and put it away. But then at the end of the day, I was going to get it out and I was going to share it with someone and make sense of it. And I think that's something that we need to do, that we need to actually compartmentalize and be aware that we've done it, but not to shut it away so completely that then we forget to process it and then it comes out at someone else. And so that's one of the reasons why I think regular supervision is so important. And that we don't get, you know, to take the think out of heart sync, that we don't avoid, you know, every time we see that patient's name on the list, that we don't go, oh, that person's coming, and that we actually feel more effective. And develop techniques to deal not just with, you know, our own reactions. Sometimes we may not be, may not have the skills to say to someone, stop, that's not okay, don't speak to me like that. And so that's important for us to train ourselves to do that, and that's why another reason for supervision. And the other things about self-care, like exercise and friends and, you know, the usual things.
Exactly. Practice what we preach, I think it's really important, isn't it? Okay, time is our enemy, and it's just running out so fast, and there's two things I quickly want to address. Just like in 30 seconds, and I'll throw to you, Tony, about just to be clear about the effective treatments that we have. And it sounds as though arousal reduction is a key aspect of it in terms of relaxation, whatever, and cognitive restructuring or cognitive therapy is important. I do seem to remember talking about things like teaching people to identify triggers and perhaps even some kind of imaginal exposure work. Just in a few 30 seconds, are those two kind of things we might include?
Triggers are very important to know what sets people off. It's fundamental. The literature around imaginal exposure for anger is really unclear. There have been a couple of studies that have shown that it actually doesn't work as effectively as it does for anxiety. So I'm interested in the research pointing to the underlying mechanisms of how these things become a problem. And I look forward to the literature talking more about what's more effective. Our treatments are moderately effective. We need to make them better.
Sure. It's probably true across the board, actually, but still. Okay, so just in the last minute before I throw to you all for your take-home messages, and I say the last minute not because I don't think it's important, I think it's very important indeed, but that is the issue of families, it is the issue of partners and families and so on. And I guess that it goes without saying, but it still needs to be said very clearly, that presumably we'd all agree that safety is a key issue that we need to be aware of, the safety of partners and children and the risk of domestic violence and so on. But do any of you have any suggestions in terms of what we can provide for families or partners in terms of tips for them to de-escalate? What should they be doing when their partner is beginning to lose it? And it'll have to be very quick, I'm afraid. But anyone got any quick take-home messages there just on that topic?
I think mutually agreed rules for how to communicate is really important. Things that are left unsaid are toxic, but there have to be rules for how couples talk about difficult things. And it's best if both parties have those rules, notwithstanding the fact that it's usually men who are expressing their anger more directly than women.
Sure. Good. Either of the others, any comments on that, on helping families to deal with this stuff?
Yeah.
Look, but I think, well, sorry, Monica, you go. Yeah.
Okay. There's one thing I was going to say is that until the person with the aggression issues thinks that they've got a problem, sometimes the members of the family are coping with it, and the other person doesn't agree to these rules, and they're not going to communicate effectively. They're just going to continue to do what they do, or they can't. They haven't undertaken their treatment. So support services for these people, like the Carers Association, COPME, which is the children of parents with a mental illness. So there are lots of things we can do. Speak to the school, let them know that that a parent has these problems. So many ways that we can support families.
Great. Thanks.
I
any
was just
final
going to
comment on
say,
that, John?
Mark, yeah, look, I strongly encourage partners of people to go and get their own help as well too. They really actually need to go and see a psychologist and get their own support for dealing with these sorts of things, rather than being a peripheral sort of factor on the sideline, because the effects on partners are just as much as they are on anyone else, and oftentimes we basically not deliberately neglect them, but they get left aside because the more immediate problem is the person in front of us. So please don't forget the partners.
Absolutely. And I would remind everybody that the next webinar is on the impact on families. And so we will be looking at this stuff in much more detail in that next webinar. So we are running out of time. Let me just say, because I'm a bit obsessional about time, that I've decided that we're going to run over by a couple of minutes because we were a couple of minutes late starting. But I would now just like some very quick final comments from our panel members, just any key take-home messages or any final comments that you'd like to make. And perhaps we'll go in the same order as we did before. So perhaps to you first, Monica, any key take-home messages?
Yeah, I suppose the idea of self-care, and also, that when we look after ourselves, we look after our patients really well. And that there are resources. I think I sent a list of resources that people will have there. And if you want to get better at dealing with people and their problematic behaviours, to do some courses around that. The APS has got some really good courses that you can do as well. So yeah, that's what I have to say.
Good. Thanks. Thanks very much. Tony, final comments?
Know what to do. The angry are less forgiving than the anxious. Treatment works. We need to get better at it. And don't forget, anger has a causal relationship with PTSD. It makes it worse, and it gets in the way of effective treatment.
Thank you. Very succinct. And John, some final take-home messages?
Yep, just quickly, please make sure that the underlying conditions of anxiety, depression and PTSD are being managed effectively. And in terms of pharmacotherapy, talking about an effective antidepressant medication, please stay away from benzodiazepines, because they're not going to be effective and then just cause further substance dependence problems. Something that can be useful is clonidine, because it's an alpha-1 antagonist, and that certainly helps decrease irritability, agitation, and therefore expressions of anger. So that can be a really, really useful tool to have in the inner pocket when you're dealing with a veterans community.
Great. Thank you so much to the panel. I just wish we had twice the amount of time actually to talk about these issues, but we haven't. So I've got to make just a few quick closing comments. The first will be to draw people's attention to the local practitioner networks that are supported and run by MHPN. Very valuable resource to allow clinicians from different disciplines to get together and to share tips and experiences and support each other and so on. So if you're interested in that, do tick the appropriate box on the evaluation form and someone from MHPN will get in touch with you. There are a number of resources associated with this webinar that have been suggested by our panel and also by DVA. And although it says there you can click the bottom right-hand corner of your screen, which you can, more importantly, all of those resources will be available on the DVA ATTE's website and the MHPN website when the podcast and video cast is put up. So do have a look at those resources, all sorts of really good stuff there. If I can please encourage everybody to complete the feedback survey before you log out. It will appear on the screen before the session closes. And my understanding is, I'm not quite sure about this, but I think you only get your certificate of attendance if you fill in the evaluation. So that's a pretty good reason to do so. Okay, please do keep an eye out for the next webinar, which, as I say, is going to be looking at the impact on families. And as far as I know, is going to be held late September, early October, something like that. In the meantime, I'd like to thank our panelists very much indeed for some fantastic contributions tonight. I've really enjoyed their input. I'd like to thank all of you participants very much indeed as well for your engagement, enthusiasm, and your input to this, and I hope that you found it valuable. And I look forward very much to talking to you in the next webinar. So thanks again to everybody, and good night to all.